and come there.
The amount of electrical current which is delivered to the cochlea through the cochlear implant. It is the programming of the speech processor to provide spectral and temporal information in a comfortable and meaningful form. Now, there are several ways in which this information is transferred to the cochlea through the speech processor, and there are different modes of stimulation, and mainly the modes that are used by the cochlear implant systems are the monopolar mode, in which the current flows between one active electrode and the other reference electrode is located distantly, or maybe the extracochlear electrode. The other mode is the bipolar, where the current flows between two electrodes which are placed adjacently in close proximity to one another, in which one is the active and the other is the reference electrode. Now, this information in the channels can be stimulated sequentially, that is one electrode up to the other in a particular order, which can be said, or it could be stimulated simultaneously. That is, a group of electrodes can be simultaneously stimulated. Basically, all the cochlear implant systems, they employ certain speech processing strategies, which is a set of rules for converting the acoustic sounds into electrical stimulating pattern that stimulate the hearing nerve by cochlear implant. And it provides the information which is carried through the auditory nerve, and the brain decodes that information, and it is in the form of electrical pulses. Different cochlear implant systems, they employ different speech processing strategies depending on their research and other history. Like, for example, advanced bionics, they have the SAS and the high resolution strategy, and now with 120K, the cochlear, they were earlier using the SPEAK and ACE, and now the ACE device. Medal is employing the CI strategy, and with their new pulsar implant, they have the fine hearing. MXM, Digisonic, though since I don't have any experience with the MXM, I will not be able to give much information about that, but as Anup mentioned, that it employs the fast Fourier transformation as the speech processing strategies. Anyway, it is important to have understanding of these speech processing strategies. However, for this lecture, I would not be able to give details about this, and the mapping audiologist has to be aware of what kind of speech processing strategies are utilized by the particular implant. Coming to the mapping involves not only setting the parameters, it also involves getting certain information from the implant. So whenever we are providing the information, we get two-way information. Once we provide the stimulation, we also get back some information from the implant, which helps us in knowing whether the internal component is working fine. Telemetry is the test through which we get information about the working of the electrodes. It's basically an electrical measurement that indicates how well the current flows between two electrodes of a channel, and this can be done intraoperatively as well as postoperatively. And as I mentioned, that it is the test of for the integrity of the implant and the working of the electrodes. This is how the impedance results you see in different implant systems like the advanced bionics, where you have the different channels showing the levels of the impedances. This is how it is shown on a cochlear system, and this is what is shown on the medal system, and where it shows the status of the different electrodes as okay. If
this topic is very important for us.
Any of the electrode is high, it would then indicate. It also shows that the coupling of the speech processor to the internal component is okay, and the integrity of the implant is intact. This is an example of where it shows a high impedance Well, once you have this information, if you find that certain electrodes are short or if they are high, then there may be need to either switch off those electrodes because we cannot provide information through those electrodes and they need to be shut off. Another measure that most of these systems give is the compliance level. This marking in the red are the compliance level at the individual electrodes. These are indicative of that any current levels given beyond this are of no use. That means you should not go beyond these current levels. Going beyond these current levels does not give any further information to the implantee for use, for making use of for speech purpose or any hearing purpose. So this helps the mapping audiologist to know where to stop or what other parameters to be changed rather than the current levels. Now this slide shows the equipment required for mapping. In order to map, one should have access to the hardware which is provided by the implant systems, as well as the software which connects the or which activates the speech processor and stores in the information or the map parameters. Like for example, advanced bionic have their CPI, the cochlear has the PPS or the programming code, MEDAL has DIB, and the software required is the sound wave, the custom sound, CI Studio, and now the Maestro MEDAL, and Digimap with the MXM system. It is important to know these parameters because basically these are the parameters that we are setting in a map. The most important ones are the T levels and the M levels or the MCL levels. Basically the T levels is the minimum electrical current required to stimulate the cochlea to produce a sensation of hearing, and the M levels are the levels which are most comfortable levels. At these levels the person does not feel any discomfort in terms of loudness of the sound or any irritation. And the dynamic range is the current levels that lie between the T and the M levels. The pulse width is the duration of the phase. Basically we are providing electrical impulses. So the pulse width determines the duration of one phase of the biphasic waveform, and making a change in the pulse width gives the perception of loudness or changes the perception of loudness into the implantee. Stimulation rate is another important parameter, which is the number of pulses of current that are delivered to a particular channel, and it provides the temporal information to the person. The other parameters are the volume, which helps in controlling the loudness level of the sound, the sensitivity, which takes care of the response of the microphone to the input intensity, the frequency bands, that we all know that each implant system provides a number of frequency bands to cover the complete frequency range, and which can be set, and the filter gains, which can be adjusted to give emphasis to certain frequencies depending upon the responses of the person. Therefore, setting these parameters creates an individual map, and each map is specific to each individual. That is, every individual, no two individual will have the same threshold levels, the same comfort levels, and therefore for each person this map has to be created. You cannot have a generalized map, or you cannot say, okay fine, we start with this level of settings, we just set to these levels, or maybe a child of the same age, similar hearing loss, need not have the same T and M levels, and therefore they have to be measured for every individual. The first stimulation, this is also known as the switch on, the initial stimulation hookup, several names given by different implant companies or different clinics as they call it. Usually this is done after minimum about 3 weeks, anywhere between 3 weeks to 6 weeks, depending upon the healing process after the surgery. And during this session, the external speech processor is connected to the internal component, which is surgically implanted. And mainly what we are doing at this in this session is estimating the thresholds and comfortable loudness levels through either behavioral measures or through objective measures, depending if the child is too small to respond or give any behavioral measures. Certain objective methods can also be used to establish the first map or the map at the switch on. Follow-up mapping, so the parameters that are set on the first map may not be very accurate because it is a new stimulation or new signal that the child or the adult is receiving, and the responses may not be very stable, and therefore it is necessary to have a follow-up mapping, which is done more often in the initial period after the switch on, which is within the first year of the implantation, to establish a stable and comfortable map. And fine-tuning of the map needs to be done, and therefore it is essential to have follow-up mapping, because you receive the inputs from the therapist, the parents and the teachers, and on basis of this feedback that you get, you need to shape the auditory input so as to achieve maximum, to get good speech perception. Fine-tuning may be done because there are n number of parameters that can be adjusted to achieve better speech perception. After the first year, it needs to be done at regular intervals, but not too often. Once a stable and comfortable map is achieved, it is not advisable to make too gross changes in the person's map, because it becomes difficult for the person to accept new kind of hearing, because every change that you make in the parameters can cause significant changes in the hearing pattern of the individual. So one has to make sure that the map is comfortable to the person and sufficient time is given to get used to a particular map. If we change it too often, then the person will never get, or the child will never get stable with listening to a particular map. The objective measures that can be done with the different implant system is the neural response imaging or the neural response telemetry, which is basically you get a compound action potential, a neural response to electrical stimulation, which can be measured through the software of the respective company, and they have different names for the same measurement in different implant systems. The other objective measures could be the electrically elicited stapedial reflex. I have done it on a couple of young kids and have got very good results with the ESRT. It's not at all difficult to obtain these responses, and these responses can really help in giving a comfortable map, because you then avoid any overstimulation. The other objective measure is the EABR, with which I have not any experience as such, but has been reported, and I think a couple of clinics have done it and have got good results. These objective measures can be done intraoperatively as well as post-operatively, and these findings can help to estimate or predict the TNC levels, and therefore they are helpful in mapping very young children or children who are not very cooperative for behavioral testing. This is what the programming screen on the computer looks like, with different implant systems, where here you have the M levels, the T levels, you can see the gains, you have the different strategy which can be selected. This shows the rate, the stimulation rate. You can select the filter settings, the pulse width. You can You can set the volume levels, the sensitivity, you can select, you can go live and then make the changes. Similarly, for other implant systems, like for the cochlear system, here again you have the C levels, here the T levels, the different parameters that can be set. You have this in the medal. Just like to show one example of how not to map. This is a particular case where can you see this white line? Now current levels given beyond this line should be avoided. But however, still in most of the channels, if you see, these levels have been set far above this white line. So in such cases where you feel that at this level you are not getting a good response, in those cases you need to change other parameters, like you can change the pulse width and get a response, which is what was done later, and we could get these levels and the person was comfortable, the child was comfortable. So the first figure here shows how a map should not look like. So thus mapping is an important aspect in cochlear implantation because it directly affects the outcomes. It is an ongoing process and it serves as a diagnostic tool, and it is also useful in troubleshooting. We'll just go through a few videos of the switch on. I have time. No. This is a child who is very well conditioned. She was attending pre-implant training also. So this looks like a very comfortable switch-on situation where the child is nicely conditioned and is responding to the electrical stimulation. The therapist and the parents are here. I am there at the back of this table where the child is not able to see what is happening or something is happening to her. She is so well conditioned that she is nicely keeping the toy down when she hears it. So it becomes very easy, especially when we have well conditioned children. The task of the audiologist becomes very easy. We'll just see another video. Here he is very reluctant to put on the processor, and even before it's put on, he is blaring. He's crying because he just doesn't want it. Because he's just afraid. It's not that but he just doesn't want it. And a little later you will see that he's trying to put it on him and see if he's comfortable.
చిన్నప్పుడు నీ
When we
మొహం
got
అలాగే
him to
ఉండేదేమో
play, then we observed since he was not though he was conditioned, but he was not very cooperative to do the conditioning task at that point of time. And then through his behavioral responses, we got it on. We got responses, and then we had a conservative map for him, and we put on the processor. And once the processor was on, so most of the times I'm sure who all are doing the switch on, they'll see that the children are a little reluctant, and crying is one of the response. And for once I feel little nice when the child starts crying. I know for sure that he is hearing because it's a different experience. And now you see that he is quite comfortable and responding. So at the end of it, he was quite happy listening, and we were also not worried. Of course, this is the later his therapy sessions. Another one, she's a very young child, little less, around 2 years, who's also again very well conditioned and happy to go through the whole session. The therapist and the parents. Okay, so thank you.
Tolerate sounds which are much above this comfortable level.
No, see the thing is, we say that we don't want to over amplify the electrical current. See, when we talk about the acoustic dynamic range, we have a far wide range which starts at the threshold, which is in a normal person around anywhere between 0 to 10, and the uncomfortable level comes around 110, 120. So that much a wide range, which is not so, because here we are dealing with electrical current and you cannot have the same kind of dynamic range here. Plus, if you are giving too much of electrical current, there are chances that the current will be splashing around to the electrodes and then the signal clarity is not going to be there. So we try not to give too much of amplification, to keep it at a level where the person is comfortable. If we go on stimulating, since the other nerves are also nearby, there are chances of stimulating those nerves, and then you can get you can stimulate the facial nerve, you can get some facial twitching, etc., which you don't require. That is why we need to keep it within the comfort level and not go beyond. It should be loud enough for the person to be able to hear and comprehend, but you need not let it be loud, because still they'll be able to hear the loud sounds, but then automatically, depending on the implant, it would be something like what an AGC was.
Can I add to that?
Yeah.
I think what she's trying to ask is that she's getting confused, like we normally say in audiometry, where you have something like a most comfortable level, and then you have a loudness discomfort level, which is significantly above, and your dynamic range goes above your most comfortable. Here it's more like it's the maximum comfortable level. So what you're setting the C levels is not your most comfortable level really, it's your maximum comfort level. So you don't want to increase the stimulation above that. So it is reaching to the uppermost part of your dynamic range. And if you go above that, obviously you're getting discomfort. So you're setting it at the and you're going to look at it as you go up. Either the child is showing behavior like, for example, twitching or any kind of usual, you know what kind of behaviors children or adults show when they have a problem tolerating the sound. So you're setting the current level, you're setting the current level just below the level at which it's going to be uncomfortable. You make sure you validate that properly even in the live mode before you send the child home with that map.
I just say one more thing with her permission. See, why cochlear implant is done is to get effective auditory stimulation. What we are really aiming when we are doing mapping is, those parameters which are set, T level and C level. As she said, validate. What she means by validating is make sure that the person gets a soft speech and tolerance to the loud sound. So, post mapping, it will be addressed in the afternoon, those things what we do. But to make sure that the person is getting a percept to the whole speech spectrum, including sound test, other assessment, make sure that you give proper access to the speech and try some soft speech also, soft voice, soft conversation, make loud noise. So this is what is the aim of the cochlear implant. They may hear when there's a loud sound, they may hear it loud, but if you have set the levels properly, it will not be uncomfortably loud. If they can make out those timing clues and envelope clues and everything they can make use of. So the soft will be, perceived soft, the loud will be perceived louder, but comfortable.
Yeah, and one more thing, you said that the child was not ready to wear a processor, during switch on. That is why there is a general thing in the pre-implant therapy itself, during the process, the habilitation is use a dummy implant before the surgery.
No, it was that the child was, that was not the problem. Just at that particular
He
moment,
didn't want
the
to wear
child
it.
didn't want to
The
wear
calculation.
it. But at the end, we saw that
No,
he
but
was
this thing
happy
is,
with
I
it
just
and
want to
he was so-
emphasize that this thing is available, dummy implant processors are
And the
available.
child has been
And most of the centers are
regularly
using it.
wearing, he is very well conditioned, but though he's so well, he was so well conditioned, at that particular moment, he didn't want to do it. And then we got him to do it.
It's very different wearing a hearing aid,
Wearing
having only
an-
this and having an implant, including the body worn thing. So generally, if you give a dummy processor 10 days before, and the child comes into the session for switch on wearing that, and all you do is nonchalantly take that and put this one on. That's about it.
It doesn't happen that often. This was one particular.
Yeah, but I mean, you know,
No, this is just a suggestion, especially for for the beginners, because there's always something to learn every, update. I mean. They've had a surgery too, so many kids are very touchy, they don't want you to touch them. Yeah, I think this thing will be covered, I think, in DP's lecture, so.
I have two doubts. One is regarding the impedance that you said. You said it should not be too high. So is there a particular level
Yes.
that, so what is that?
There are it is different, the particular levels are little different with the different implant systems, and they are shown on the test
Okay,
itself, where it gives the status
Yeah.
that beyond this it is going high, so it gives an indication, and therefore you can accordingly either switch it off. If it is short, it shows on your test, on the results.
And the second one is regarding, if you could just elaborate on pulse width and volume. You said pulse width is changed for loudness, and then the second thing you said is also
There are
volume.
different ways of changing the loudness. Basically, volume works with your M levels or the C levels,
Okay.
where you are reducing or increasing, your M levels are set accordingly. Whereas, though your M levels are at a particular current levels, increasing the pulse width, with the same M levels, you can get a louder percept by changing the pulse width.
Okay. Thank you.
What you do is, it's like you set a map, using those parameters, which are M level, T level. If needed, you change the pulse width, and then when you give a map to the person, because we are even doing in our clinic, which are quiet, though we make loud sound, make sure that it's not uncomfortably set levels. But when they go out in the real world, if they feel loud, they get just some control to work on, that's volume control. Or, they have got sensitivity, which she mentioned. How much distance sound you want to pick up, how much closer sound you want to pick up. So those controls are given. Those are fine-tuning kind of a thing, and pulse width is basic map. Yeah, patient can control.
Rahul.
Only two questions.
Yeah, now you can ask.
See, as you mentioned, at the first mapping, some objective tests are also done. So after each mapping, or even after that, any other test is we do, we just to, after doing a mapping,
You can do an aided, you can check the aided responses of the child in a sound-free situation to see how well across the frequency the child is responding.
but are there any speech tests is also done?
Depending at what level, if you can even do a speech discrimination for a speech
Shabnam, this is all going to be talked about in Geeti's lecture, so I don't think we should be talking about it. It's not fair to her, otherwise her lecture won't have any meaning. And another thing to add,
Just one question, huh?
I'd like to know.
That saves me to answer a question.
no, this lectures are going to have certain things overlapping, but obviously we are trying to bring down as much overlap as possible.
From day one, how should be the frequency of mapping, and when do you identify that map has been stable, and how much importance do you give to forward frequencies correlation for particular bandwidth of map?
The frequency of mapping varies from clinic to clinic. I can tell you what pattern we follow. Is at the initial map, that is the switch on. Generally, most of the implants, they have a provision of giving up to 3 to 4 maps. So depending on how well the child is conditioned, you know at your first mapping when next to call the child for mapping. If the child is well conditioned and you are able to obtain fairly good threshold levels or the comfort levels, you can give progressive maps wherein over a period of time the parents can use them one after the other over a period of time. So anywhere, or if you find that on the first stimulation itself the child has not responded well, you may call the child the next day or day after again. But most of our children who are well conditioned, they require after the initial map about maximum a week to 2 weeks time for the next mapping. And actually every mapping you can decide when next to call. Initially it is at least once in a month in the first year. And once you get a stable, comfortable, when you are sure that the thresholds are well established, you are not finding much variation in the threshold at different channels, your aided graph looks well within the 30 dB range, then once in 3 months, then once in 6 months, and then once in a year, and so forth. Because but mapping at least once in a year after say 2 years of implant use has to be done, because as I told, it's not only setting the parameters but it's also a diagnostic tool.
About the format.
About the format, that depends. See, when you're doing your follow-up mappings, as I had mentioned, that you have to have a feedback from your therapist, the parents about what sounds the child is able to pick up, what they're responding to. On that basis, it can be formed. And I think Ms. Aziza Tayebji has formed some grid which can be used to determine that. I don't know much details. I think Fatima can give better information about
Yeah,
that.
I think Fatima, just one thing I'd like to tell, that initially when you're setting a map, the first thing, it's a very conservative map only for the child to take in that information, to be comfortable. And every clinic has a different procedure, but I think you should call them at least weekly for a first month, and then maybe 15 days, and then you yourself come to know how soon the map is, fixed or set. So, Fatima, do you want to say anything before?
I just wanted to add that in the marathon protocol, that earlier even we used to not map the child till 6 months, once the map is stable. But of late we have been finding that when we call the children later on, their T's and C's really go haywire. So now we have made it a rule, at least every 3 months children are mapped.
Yeah. Okay, we can split for lunch now, but just make sure you're here. I'll say 20 minutes, but I'll stretch that to half an hour.
Okay, one more announcement. The surgeons who are going for the dissection, one of the residents will accompany each batch. So,
Intervention Center in Mumbai that works with hearing impaired infants and babies below 18 months of age. Topic for her discussion today is importance of counseling in setting experts.
That it is the second one.
Oh, sorry.
I'd ask you to switch this.
Okay, sorry. Assessment of progress.
Yes.
Please go ahead.
Is there any way that I can ask all of you to come in the front, because the most non-threatening topic?
I think
No questions will be asked.
everybody, please come in front. Everybody come in front. Don't leave empty spaces in